My name is Julie Smith. My student number is 09510-192, and this is my reflection for my Capstone unit on interprofessional communication. Interprofessional communication is defined by the World Health Organization as multiple health workers from different professional backgrounds working together with patients, families, caregivers, and communities to deliver the highest quality care. For Rhonda 2016 confirmed miscommunication has a high correlation to poor patient outcomes and is well documented. Paramedics are continuously communicating interprofessionally between doctors, nurses, allied health, patients, and their families in order to assess, treat, and subsequently pass on their healthcare to other individuals to ensure optimal outcomes for the individual's health and well-being. In my opinion, effective communication is one of the most important skills a paramedic can have. Whilst this is also important for other professions, such as doctors and nurses, paramedics often deal with a much broader demographic in a shorter time frame. We go from communicating with patients, families, and bystanders on scene, as well as other paramedics, to then nurses, doctors, and allied health staff, all within the space of one case. A process which is then repeated multiple times a day in fluctuating circumstances, demographics, and social situations. Failure to effectively communicate results in delays in testing and treatment, drug errors, misdiagnoses, and can lead to patient health adversities or even death, according to the Australian Commission on Safety and Quality in Healthcare 2012. Thus, effective communication skills, for me, as a graduate paramedic, is of great relevance to my future practice. A literature review by Bost 2010 into the clinical handover of patients arriving by ambulance to the emergency department highlighted that an estimated 1.6 million handovers occur annually within Australian hospitals between ambulance services and emergency departments. The environment in which this occurs is a high acuity, overcrowded setting whereby an environment full of distractions and interruptions are cultivated that is subsequently deleterious to the quality of clinical handovers. One of many contributors to poor interprofessional communication and subsequent patient outcomes. Communication between various practitioners in the clinical handover setting is a major source of medical error and has many defined sources. These include handover method, language used, education levels, experience, and varying terminology, as according to Bost 2012. Unfortunately, it is the patient that suffers because of this communication breakdown and can have varying effects on their overall care and subsequent management. Upon reflecting upon interprofessional communication in my limited experience in the healthcare sphere, one incident especially highlights its importance. We had just attended an elderly patient who had suffered a fall in her home and subsequently had a query fractured shoulder. As a result, we treated this patient with a total 10 mg IV morphine, the maximum dose for her age, and proceeded to take her to hospital. After handing over and being offloaded at triage, we proceeded to finish the paperwork. Upon returning, we discovered that the patient had been placed in the waiting room. After discussing the appropriateness of this decision with the nursing staff and my clinical opinion, the patient was reassessed and moved into a bed space. In this situation, I had not clearly communicated with the triage nurse my high index of suspicion for a fracture. The patient was subsequently found to have a limb-threatening fracture of her humerus, as well as being significantly affected by the large dose of morphine she had received. Whilst this case was recognised and rectified before harm could be done, it raises the question of how many other patients under my care have been adversely affected by an interprofessional communication failure. Another identified issue towards interprofessional communication is varying handover methods. Different paramedics, nursing, and other medical staff use varying handover techniques and have differing knowledge, which can result in misunderstanding and even perceived inattention and result in inactive listening skills. Additional to this, different hospitals also have varying policies and procedures. The Australian Commission on Safety and Quality in Healthcare developed the National Safety and Quality Health Service Standards, of which it defined clinical handover as one of its targets. As stated in the Standards Report of 2012, current handover processes are highly variable and may be unreliable, causing clinical handover to be a high-risk area for patient safety. It proposed that improvement of this requires a standardised process and information set, as well as monitored evaluating processes to ensure positive outcomes. Whilst I believe this is a positive step towards addressing this issue, its implementations for paramedics would be difficult. In the instance of the Queensland Ambulance Service, organisational management has its own operational and strategic direction distinct from Queensland Health, and as such, continuing professional development and in-service training is conducted separately. Moreover, ambulance services interact with the private sector also, which have different policies again. As such, standardised clinical handover will continue to be an issue for interprofessional communication in my future as a paramedic. I believe the greatest barriers to my effective interprofessional communication is lack of experience, as well as the difference in common language between professions, all very well documented issues in this area, as according to BOST 2010. Whilst clinical handovers and communication are addressed at university, little is done by way of practicing this skill prior to being on road and being expected to provide an appropriate one. Education reform, coupled with an interprofessional training model, is a recommendation of current literature. Reflecting on my university studies, very little interprofessional communication interaction or teaching was undertaken throughout the degree. Swihart 2016 explored the interprofessional collaborative practice competencies in patient-centred medical homes, with one of the 4 competencies for success being an interprofessional communication. Among its recommendation was openness and common language as opposed to professional jargon, as well as tools for checking understanding, such as write down, read back, and active listening. I found this was not an actively taught skill throughout my studies and would be a beneficial point for educational reform. Interprofessional education has long been proven an important pedagogical approach in preparing health professionals, especially, and is well supported by many organisations, such as the World Health Organization and the Institute of Medicine, as well as vast literature. Interprofessional education, as defined by Bering 2009, is 2 or more medical professions jointly creating a collaborative learning environment to foster skills, attitudes, and knowledge that promotes patient-centred interdisciplinary team care and understanding of interprofessional roles. By having this understanding and practice, it has been found that patients receive safer and higher quality care. Whilst I interacted with various nursing students throughout the degree and completed one assessment in collaboration with podiatry students, this is hardly conducive to fostering lifelong interprofessional communication skills. Bering 2009 suggests interprofessional education should ideally be incorporated throughout the entire curriculum. Whilst these aforementioned changes, I believe, would help develop my interprofessional communication and improve my self-defined deficiencies, nothing can substitute practical experience that can only be developed by years of clinical experience in the field. As previously noted, there have been occasions where I have identified an interprofessional communication breakdown that has led to an adverse event, and suspect there are many more situations where this has occurred without my knowledge. However, there have been many situations in which I believe good interprofessional communication has been especially notable on the patient outcome and further validates its importance. For example, we attended a patient who had suffered a low-mechanism bicycle accident early in the day and was suffering some grazing and worsening shoulder and back pain. The patient presented hemodynamically stable with us, the only issue being his pain. However, his general appearance was ashen, and I suspected there was an underlying pathology. After managing his pain, we transported him to the local hospital. After communicating my nondescript concerns with the triage nurse and effectively describing the events leading to this presentation and his clinical syndrome, the patient was prophylactically accepted into resus. The patient was left stable and well when we left the hospital. After following up a couple hours later, we were informed the patient crashed in resus, had significant internal injuries, and was rushed to theatre for a difficult intubation and emergency surgery. The triage nurse commended me on my handover and stated he would otherwise have gone to an acute bed if I had not voiced my concerns. This is an example whereby clinical data and vital signs had little effect on the clinical outcome of this patient. Instead, the information that had been obtained from the patient and his wife, coupled with his physical presentation and objective data, meant that I then effectively communicated my findings and concerns interprofessionally to have an evidence-positive outcome on patient care. This case in particular solidified the importance of good interprofessional communication in my practice as a paramedic and is of great relevance to my future practice in the field. As such, I remember this case and how I managed it to hopefully adapt my future practice to have similar positive outcomes. After reflecting in depth on the topic of interprofessional communication in my future practice as a paramedic, I've become aware of the complexity and clinical importance it presents in this profession. From previously detailed experiences, as well as further literature research, it is evident that there are many deficiencies in both university teachings as well as organisational structure and procedure. Such deficiencies include clinical handover miscommunication, varying education levels between disciplines, varying communication methods, lack of experience, and insufficient interprofessional education. Notwithstanding, I have also experienced cases whereby interprofessional communication was conducted well, subsequently justifying its importance and exemplifying its advantages. Whilst there is still much that can be done to improve both mine and general interprofessional communication on road, it has been evidenced that current processes can be effective. As such, one can conclude that interprofessional communication forms a substantial part of my role as a paramedic and will continue to do so into my future practice. Thank you.